Right. So as I said, I don't think there's anyone else. In case people join, we'll look at that. But otherwise, please feel free to stop. And we could I've just put some slides so that we have a little bit of an idea of what we're doing, but it doesn't need to be like that. So basically, just trying to cover epidemiology, a bit about pathophysiology and the latest international guidelines, which are now nearly 4 years old. What kind of monitoring we use at the baseline ICP monitoring, and what kind of advanced data monitoring. We're looking at what exact thresholds we're using for ICP and CPP, and some discussion around whether that's the right number or whether we should be looking at doing something else, and the treatments, of course. So we do know that brain injury kills 5 times more children than cancer, but clearly the research input into the evidence is much smaller in comparison. And nearly 1/4 of the admissions that we have in PICU would either have an underlying neurological diagnosis or would be at a risk of acute neurological injury purely because they are unaware. So and there's certainly a high incidence of traumatic brain injury. And those who require intensive care, nearly 50% of those would have poor neurological outcomes at 6 months. So and it is worse for pediatric population because the productive life years lost in that is much greater than in an adult. And I know the $1 million question that people used to ask all the time was whether it is better to have the same injury at the age of 5 or 25. And it was always believed that 5 was a better age because children have more neuroplasticity and probably have better outcomes. But there's an increasing recognition that although their initial outcomes are better than adults, but equally, what do we call a good outcome in a child who's 5, so that they come back to the baseline of 5, or whether they do you want us to stop, Naz?
No, carry on.
Or whether, because if an year or 2 years after their injury, they come back to their baseline at 5, they still have an entire developmental trajectory because they need to achieve all the developmental milestones and the cognitive maturity. And that is severely hampered because they do not have the scaffolding of the neurons. So if some are lost, some other pathways can take over when we are fully mature and adults. While in pediatric population, that scaffolding doesn't exist. So whether or not any other neurons or any other circuits can take up that function is highly controversial. And despite the fact that we do not have, I mean, when you look at the TBI and the acute neurological diagnosis, probably about 10 to 15% of our total number of admissions would fall in that category. But nearly 65% of the deaths that we see in PICU are related to brain injury. Majority of them are withdrawal of life-sustaining therapy, but equally that's the big contributing factor. So although here it says January 2017-18, actually this is the latest TAN-led report that has come out of the severe injuries in pediatrics. And of course, the most significant severe injury we see in pediatric age group is traumatic brain injury related to morbidity and mortality. So if we look at the entire population of children attending emergency departments across the country with injury, there are about 4 million. Out of those, less than 5,000 would hit the TAN criteria for submission. Sunil, I'm not sure how familiar you would be with the TAN criteria, but essentially TAN is something similar to PICANET, which is Trauma Audit and Research Network. It collects data on all patients who are admitted to hospitals with what was described as major trauma. So that is calculated by the injury severity score. So they have got specific entry criteria for TAN submission. So anybody who's got ISS greater than 15, those who are admitted for more than 72 hours, etc. Like, you know, there are specific criteria.
And
but
who will report it?
They are all reported, and they produce similar reports at all.
Like if the child get admitted in PICU and ward?
Yes, anywhere. So there is a TAN office, so similar to the PICANET, and the patients would be highlighted. So they're initially called a major candidate, major trauma candidate patient, because the injury severity score is what we would give them in retrospect. you won't know exactly how many bones are fractured and what other internal injuries a patient has when they arrive in the emergency department. But based upon the mechanism of injury, their physiological instability, you could call them a candidate major trauma patient, and they would come on the trauma list. And then based upon their entire imaging and radiology reporting, they would be allocated a injury severity score based upon the specific organs and bones involved. And there's been an entire list. It's very similar to our PIM scoring. And interestingly, there is some evidence to looking specifically for children as to how those who require critical care in terms of the PIM is what we would use. For, you guys may not be familiar with that, but just like you use Apache scores, in pediatrics, we use the pediatric index of mortality, and it's the third iteration of that, where we look at mainly the physiological instability on admission, which then gives a predicted score of outcome, similar to the ISS. And interestingly, what they have found is that because we would be, each of these trauma patients admitted to ICU will get a PIM score, and they'll also get an ISS score. So ISS is better at predicting their outcomes towards the older age groups in the adolescent years, while PIM is better at predicting the trauma outcomes. Hi, Alex. Trauma outcomes at the lower end of age group score, and that it makes physiological sense, because when you are an adolescent, what is more important in terms of defining your outcome is what injuries you have, right? Because your physiology is hopefully more like an adult. So injury severity score is more significant, whilst at the lower spectrum, their physiological instability defines how good or bad they perform in terms of their eventual outcome. So out of the 5,000 odd patients, and the injury severity, so the major trauma is defined as ISS greater than 15, but Town would collect data from any patients above greater than 8. So the total numbers are still fairly small, and consistently the same. If you look at last 10 years of Town-led report, the actual ISS greater than 15 sits somewhere around 1,500. So that has not necessarily changed. And when we look at the age groups, we see a 2-peak pattern. So under ones, and unfortunately under ones is the age group where we see a lot of non-accidental injuries, because these are mainly non-mobile children, and they would have fall associated injuries, either accidental at home whilst the parent is feeding or turned around and the child moves, or significant physical abuse. And then it seems to settle down till they reach risk-taking behavior in their early teens, and then start cycling and becoming more independent.
Presumably there is a gender.
Males, of course, yes, absolutely. And if you look at year on year, the numbers haven't changed. And please do remember that we're talking mainly about major trauma. So those who get most severe injury, of course, just like adults, are road traffic collisions, followed by falls, NAI and under 2. And when you look at interestingly, when you look at the spread of children under 1, these are age and months. So we see a peak below 4 months of age. So for you, because you and Alex is also from adult background, so the hypothesis is that that's the age where children cry a lot. And if there are anger management issues in the parents, they would not know how to handle that. And they sometimes would end up shaking the child just to stop them from crying. And they have launched a nationwide campaign called the ICON, which is putting out pamphlets and using antenatal classes and nurseries to teach parents as to how they should manage a crying child. And basically saying, if the child's crying and you feel helpless and unable to help, make the child safe and walk away, have a cup of tea, etc. And this is the age where they cry the most, and then things settle. So just trying to reduce the numbers. And this was trialed in Victoria in Australia, and has led to a significant difference in the incidence of child abuse. And of course, we were worried about the pandemic because everybody was cocooned at home, and there is some suggestion that we might have had more non-accidental injuries. So that's how the numbers are. Clearly, there is a slight increase in the penetrating trauma that certain regions of the country are seeing. And this is when we look at traumatic brain injury. Of course, again, very self-explanatory. When you look at it, the road traffic collisions keep increasing as you increase in the age, whilst in the younger population, it is mainly the falls that lead to non-accidental injury. And of course, the NAI forms more than 50% of what we would have in the younger age group. And when we look at the percentage of patients, those who would fall in the ISS greater than 15 category, the head injury is the biggest number.
Interestingly, if you go back on the slide, the thoracic injury comes as ever close to 20%.
Yeah.
Presumably that's in pediatric cohort of patients. And I've looked at the TAN statistics about adults, about exactly thoracics, and it's actually the same. 25% of the ED admissions are thoracic injury.
Yeah.
Very similar data.
Yeah. Although the pattern of thoracic injuries you would see in adults and pediatrics very different.
Yeah.
And I know I'm not focusing on trauma today, but that's like, yeah. So that's, I mean, limb injuries are, of course, the commonest trauma we would see in pediatrics. I'm sure that's what we must be the adult figure as well, but we're mainly talking about the major injuries that come. So if we look at the severity of TBI, majority are mild, thankfully. So between 70 to 90% are mild traumatic brain injuries. And unfortunately, the denominator is not very well known because it's a very difficult population to define, and we've been trying to work out on whether we can create a registry and include all the patients with that. And less than 10% of these are what would be considered as clinically significant traumatic brain injury. And even out of those, less than 1% require some kind of neurosurgical intervention. And 15% moderate and about 5% severe traumatic brain injuries, with 60% of these living with some form of disability after all. So when we look at the entire cohort, the mortality actually seems fairly minimal. It's only 0.4, but there's an increasing interest in trying to understand how the mild traumatic brain injury or the so-called concussions affect the antisocial behavior or some kind of psychiatric problems once they become adults. And the answer is not very well known. And the key factors that have been shown an association with TBI are deprivation, some kind of underlying neurological issues. Of course, we talked about falls and road traffic accident. And interestingly, half of these occur at home when it comes to children. So when we look at the actual injury, well, of course, we all know that at the time of the actual injury, the brain sustains what is defined as a primary brain injury, either focal or diffuse or a combination of the two. So where where there's a site of impact, and then followed on from there, there is some kind of a shaking injury within the brain, and then because it's a fixed compartment, the friction along the bony margins as well as the ligaments lead to further injury. And of course, there is the focal. When we look at it, there's contact and impact. Mainly what we see with that are fractures and epidural hematomas and contusions, whilst with diffuse injuries, we see deceleration injuries, more subdural hematomas, intradural hemorrhages, and diffuse axonal injuries. So when it comes to epidural or extradural hematomas, we know that majority of these would occur with minor head injuries, and usually due to a meningeal vessel or a dural sinus rupture associated with a skull fracture. Nearly 1/3 of these children would have some sort of lucid interval, but it's non-specific, and they can present with confusion, agitation, and focal neurological deficits. Subdural hematoma is a bit more malicious, and we tend to see that more often in non-accidental injuries. Certainly has worse outcome, and usually caused by higher velocity impacts and assaults. and fall from significant heights. They usually could be associated more frequently than the extradural with cerebral contusions and diffuse axonal injuries. And of course, we know how to make the diagnosis between extradural and subdural hematomas. 50% of these children would be unconscious immediately, and the focal deficits are more common in them, mainly hemiparesis, seizures, and pupillary abnormality. Majority of the pediatric subdurals would be treated conservatively. Very infrequently, we'd send them for some kind of evacuation. So we know that the primary injury then leads to multiple different pathophysiological cascades, which contribute to secondary brain injury. And that's what our role is when they come to intensive care. So the primary brain injury goes into the preventative remit, because we can't do anything once it has happened. But the secondary injury is what we are focusing on. And mainly because there is tissue damage that then causes cytotoxic and vasogenic edema that worsens the brain swelling, and then causes increase in intracranial pressure. And because we are in a fixed compartment, that then affects the perfusion, causes further ischemic damage, and it becomes a vicious cycle. We do know that the injury processes are sequentially activated and could go on for as long as a week to 10 days, and sometimes even longer. The cytotoxic edema starts early and then peaks earliest, and then the vascular incontinent and vasogenic edema follow. So the key pathological problems that we try to manage and identify in intensive care are, of course, related to cerebral blood flow. That's why we're so focused on managing blood pressure, because there is impaired autoregulation and brain edema. And we also focus our management on the ICP to try and optimize the cerebral blood flow. The energy flow, clearly very difficult to measure and understand whilst the patient is being managed. Some of you who worked on an NCCU would probably have seen the microdialysis, and we're trying to start using that in pediatrics. But clearly the issue with that is it's a focal number, and we're still trying to understand whether it would make a huge difference to the patient's outcome at large. But glucose utilization and availability. So in pediatric TBI, we went through a phase where we were trying to do a very tight glycemic control, but then we realized that that led to glucopenia in the brain, and we now manage their sugars more around normal glycemia range and have a much higher threshold to start using insulin to treat them. We know that the initial hyperglycemia is related to the stress of the injury rather than being pathological in itself. And mitochondrial failure, as we can get from lactate pyruvate ratio clearly, is something which the adult teams are using, although again, only in certain select centers. And oxygen, of course. So the two key factors that make the biggest difference to a patient's outcome post-head injury are oxygen and blood flow getting into the brain. So we try to avoid hypoxia and ischemia by managing normal oxygenation, trying to maintain child's ventilation appropriately. And clearly there is an oxygen supply demand problem, as well as utilization, which is related to mitochondrial failure. And brain tissue oxygenation gives us some idea as to whether we are delivering appropriately or whether the utilization is a problem, in combination of the other parameters that we can study. Again, the big issue with brain tissue oxygenation is it's a regional number. It's resource intense, and we are all awaiting the results from those three to see whether it really makes a difference. But some pediatric evidence that it has, in combination with ICP and CPP, triggered treatment, it makes a difference to the patient's outcome. And last but not the least, of course, excitotoxicity and seizures. And there's an increasing understanding as well as interest in defining the spreading depolarizations as well. again, something really complex and done only in a few centers, because we may not be able to pick that from surface EEGs, and what they need is an intracranial EEG, which is again not used very commonly. And it's quite easy to understand why the brain's excitotoxicity thresholds would change post-injury, because of course there are so many hemodynamic changes happening inside the brain, as well as release of excessive neurotransmitters. And although I'll not go into the details, but again, with increasing use of continuous EEG monitoring, people are using not just, of course, the seizures, but also the background EEG patterns, which have some implication for prognosis as to how well or badly the patient could do. And we still use prophylactic anti-seizure drugs based upon our clinical algorithms. People who are using continuous EEG more frequently, whether or not they're using more or less anticonvulsants, still to be proven. And equally, not just in TBI, but in other patients in pediatric population where they're using continuous EEG, they're identifying more seizures, but whether or not treating those seizures makes a difference to the patient's outcome is yet to be.
So they all get anti-epileptic?
No.
They don't.
That's what the
Some
recommendations in adults are.
We
You don't
don't.
start prophylactic antibiotics.
don't.
If there are evidence of seizure, you continue on for 7
Yes.
days, because the outcome, even with seizures, is not bad.
Yeah.
So it's a upset brain rather than.
But wasn't that saying that in peds you do it differently? Do a
So yes, you're right. I mean, the prophylactic anticonvulsants are only good to prevent the early seizures post-injury. They are not good at preventing the long-term epilepsy that could happen. Some people believe that the jury is still out there, not quite fixed on whether we should be using prophylactic anticonvulsants more without doing EEG, because EEG might actually hamper, because you're now waiting for seizures to happen, or whether it's too late to wait for you to. Most of the times we use it as a part of tier 2, or when we see some kind of a physiological marker suggestive of seizures, because majority of these children will be heavily sedated and paralyzed. But a low threshold if they've got intracranial blood to start using it. And sometimes it's kind of also decided by the neurosurgeon, who says, oh, put the patient on
That's my
anti-epileptic.
personal preference. Yes, please.
So, so that's what we're looking at, and that's what we work on. So we try to, and that sort of explains the neuroprotection basically as what we're doing. We're preventing hypoxia, hypotension, extremes of anything really. Although we talk about hypoxia more, there's clearly some evidence to suggest that hyperoxia early on post-arrest and post-TBI has worse neurodevelopmental outcomes. Whether that's a reflection of poor utilization or actually increased delivery and increased free radical damage, we don't know yet. We try to keep everything normal glucose, normal temperature, normal blood pressure, normal oxygen, and normal CO2 basically. So when it comes to stabilization, of course, like we would for any other patient, APLS, EPLS, ATLS, whatever approach one wants to use. When we're talking about trauma, we sort of start talking about primary survey, secondary survey, more than just saying ABC. The primary survey is ABC. But the idea is that we try to identify the life-threatening injuries. We fix that before we move on to the next stage. And then once we have resuscitated the patient, to complete a secondary survey to make sure we have not missed any other injuries. And then now we're doing a tertiary survey as well. Sorry. So as I said, when we're talking about brain injury, the only thing that makes a difference is ABC mainly. So blood and oxygen going to the brain. So aggressive airway and breathing management, and active avoidance of hypertension. So only 2 things that have shown a clear-cut association with outcome are pre-hospital hypoxia and hypertension. So if we can somehow avoid that, it'd be a good thing. It's clearly still a challenge to intubate these children pre-hospitally, because the pre-hospital teams may or may not have enough exposure to intubating a small child. So they do use supraglottic devices sometimes, and sometimes intubate. C-spine immobilization, I think that practice might differ slightly between adults and pediatrics. In adults, probably radiological clearance is easier and commoner, whilst in pediatrics, we still want to protect the C-spines, especially in a child who's unconscious or who's on full neuroprotection, till we've either done a clinical clearance or we do an MRI clearance. So when I say radiological clearance, I should specify, I mean CT scan. And the main reason is the scivora is more common in pediatrics because they don't have fully ossified bones and cartilage yet, and they can have injuries which may not be detectable on CT scan. In fact, people are questioning whether scivora should be called scivora because it's spinal cord injury without any radiological abnormality, but there is radiological abnormality on MRI, not on CT. So people are thinking about redefining the terminology around that. So I think there was some confusion around C-spine immobilization because APLS, I think in 2016 or just before that, said we don't need to immobilize the C-spine. And I think there was a clear need to do that, mainly in those children who were awake and crying. It was extremely difficult to keep them stable just because they had trauma. And there was evidence that trying to put an ill-fitting C-spine collar was making it worse for them. So now we've moved away from that, but I think it did confuse people because they thought, oh, the collars are out of the window and they've gone in the bin. But clearly the collars are not out of the window, but we just have to think about where we're using them. So we do have to immobilize or protect those spines that the child cannot do themselves. If they're awake and crying, clearly they know what the best position for them is. So all children with altered level of consciousness or those who are sedated, paralyzed should be. In those, we feel that the mechanism of injury could have resulted in significant injury to the spine. And of course, all children who have signs and symptoms consistent with spinal cord injury. And although we talk about scivora, actually, to be honest, we do not see that as often in pediatric populations as well. We did some retrospective work in our own cohort. Certainly the spinal injuries, I'm not saying spinal cord, I'm just saying spinal injuries are way more than what is reported nationally. And because you just have to see one or two children who then have a cord injury in association that you start worrying about that. So as a protocol, our policy is to keep their C-spine protected till we have woken them up. And if they're cognitively well enough to have a clinical clearance, we do that. Otherwise, we would normally do an MRI.
So in adults, there is clear association with the use of collar with distracting injuries to the neck as well as decubitus injuries. Have you noticed that in kids, and how early would you go for an MRI to clear the spine? And
so when we're talking about C-spine immobilization in a sedated, ventilated patient, you're not using a collar. You only put the collar when you're moving the patient. You're basically using bags and tapes. So you are not causing any decubitus injury. And we would normally try to do an MRI spine if for whatever reason we're doing an MRI head, but clearly not whilst they are requiring inotropes around the state.
Yeah.
So,
but I mean, if the child is not waking up as you would expect in 48 hours down the line, would you wait for another day or?
So usually we would, if for example, let's assume that everything else is fine, their ICP is low enough and there's nothing specific on the CT scan, and you think after 48, 72 hours, you can start waking up the patient. You start waking the patient up and they're not fully awake. So we just wait. Okay. We'd still continue protecting their C-spine. Unless then it seems like we might have missed something. If there was a diffuse axonal injury which was missed on the CT, then you're taking them for an MRI, you do spine as well at the same time. So that would be our course. And of course, just a little bit about network coordination service, which are based here at Addenbrooke's. and they help with the initial decision making with the head injuries. And Panda, of course, is now not so new, 2 years, and they're another port of call. So the Trauma East Manual of Procedures and Operations has all the guidelines, and there are pediatric guidelines as well within that embedded, which talk about how we manage a traumatic brain injury or a trauma patient. So we can now download it on our phone and use it. So these are the local, I mean, not local, the regional guidelines for children. Of course, when it comes to neuroimaging in the acute phase, CT is the imaging of choice, mainly used to diagnose surgical lesions. And we do not repeat it with specific time interval. We only repeat if either there's a change in neurological exam, or there's a sudden spike in ICP, or there's, for any other polytrauma, we cannot assess the patient and they need to stay sedated, or in case the patient's not improving. CT can also, of course, give us helpful indicators in terms of the severity of illness. And there are well-defined scoring methods when it comes to trauma. So both Rotterdam and Marshall scoring systems are used in pediatrics as well. So mainly looking at the basal cisterns, midline shift, mass lesions, and the subarachnoid intraventricular hemorrhages. And a slightly different scoring method, but pretty much looking at the same variables in the Marshall scoring category as well. So how do we decide whether or not we're doing a CT? Well, of course, immediately if we suspect there is non-accidental injury in a child, seizures, and specifically in those children who do not have epilepsy, and then there are clear-cut guidelines, probably not go into the details of what the NICE criteria are for urgent CT scanning in emergency setting. And these are the PCAN rules, because they realized that from the NICE head injury imaging criteria, they were having to do a lot more CTs than they felt clinically were required for children. So then the PCAN has produced some further guidance, which hopefully reduces. I mean, I think if we were to do an audit on following the NICE guidelines for head injury CT criteria, we would probably fall short. But that is clinically appropriate because we do not want to subject these children to unnecessary CT scans. Right. So although I haven't put up a slide here of what are neuroprotective measures we would follow, but essentially what we tend to do is what in our protocol we define as baseline neuroprotection, which is intubation, ventilation, managing them with midline, head up 30 degrees, managing their PaO2s above 12, their PCO2s between 4.5 and 5, doing volume protection, volume control mode with lung protective ventilation strategies, not using very high PEEPs, not keeping the neck obstructed to avoid any kind of venous drainage issues. And then we would, as you probably would have seen in this child who's just come, we would tend to put them directly as soon as they arrive on intensive care on a cooling blanket to manage normothermia. And I know some centers would use it only if they cannot control temperature with paracetamol and other measures. But we believe that if we allow the temperature to go up, we probably already caused some damage to the brain. So we've missed the golden period. So we would actively, aggressively manage normothermia for first 48 to 72 hours. And then early introduction of feeds, if we can, and then managing ICP and CPP guided therapy. So when we look at the recommendations from the 2019 pediatric guidelines, well, unfortunately, majority of guidelines are level 3 for ICP monitoring, and I'm sure you guys are aware of the evidence that is out there in terms of the ICP guided therapy, especially after the best trip trial. People are quite skeptical in terms of whether or not monitoring or managing ICP actually makes a huge difference to the patient's outcomes. And depending on where you look, things vary slightly. Maybe, what is that? That's not sounding good. Okay, that's fine. And then, of course, there are what is new for pediatrics is the introduction of brain oxygenation. If you can use it, and then the level that they have suggested is more than 10 millimeters, which might be too low for preventing cerebral ischemia, because, and the reason they have chosen that is because the evidence is very limited, and one of the studies showed that keeping, like, under 2, they saw more ischemic damage to the brain. But clearly, if you allow it to drop down to that level, so majority of the units where they use it, they try to keep it above 20 rather than above 10.
It's 25 in
adults, yeah. So just a little bit brief about ICP monitoring and no ICP monitoring. Clearly, there is more evidence being collected, and the Synapse ICUs, the latest that has shown that there is some benefit of using ICP monitoring. Clearly, the initial best strip trial, although they did not show any difference, they clearly were using a lot more CT scanning and prolonged more use of drugs in the non-ICP monitored group. So we still use it. And of course, we are kind of trying to manage the numbers at less than 20. We are becoming increasingly aware that it's not just a single value. It is the dose and the duration of that ICP spike, which is damaging to the brain. And if you look at this first paper that came out in 2015, it shows a clear demarcation, and although it is 20 for majority of patients between favorable and unfavorable outcome, clearly in certain patients, depending upon, we don't know yet what, even the lower value of ICP for a prolonged period of time would cause worse damage than a single spike of 20 or above. I think I'll probably just talk a little briefly about how we're trying to understand this better in terms of the intracranial compliance. And we can get some information if we look carefully at the ICP waveform, whether or not the intracranial compartment is has enough reserve to sustain that intracranial pressure. Or we can also look at the pressure volume relationship as derived by some complex equations looking at the pulse wave amplitude of the ICP against the ICP or the CPP, which can give us some indices. So there is some ongoing work, and especially for, I'm seeing 3 adult trainees. I'm sure if you've not read the Center TBI papers, but they're talking about individualizing ICP treatment thresholds and targets based upon these compensatory reserve calculations, with the idea that just as we think about CPP being targeted individually to a certain patient at a specific point in time, we might need to do something similar for ICP as well. And I don't know if I have that later in my presentation, but interestingly, there's work from here in Cambridge where they have looked at the ICP insults in relation to the CPP thresholds and to the pressure reactivity thresholds, autoregulatory indices. And the brain is able to sustain much lower ICP insults if the autoregulation is impaired than in comparison to where it is intact. So there is clearly a lot more to the physiology that we understand at this point in time. And we're kind of getting more and more complex in terms of how we're integrating this data, and clearly we need help of the machine learning techniques because it's impossible for human brain to comprehend all of that going on at the same time. So that's work in progress. But we know why we are worried about, and this is kind of the pressure volume curve. So the brain only has a limited compensatory capacity because it's a fixed compartment and has to manage a balance between the 3 or the 4 compartments, if you think about it. So the vascular compartment can be divided into arterial and venous. And although we didn't pay as much attention to the venous compartment, we are increasingly recognizing that the drainage pathway especially the sinuses, and the it can contribute hugely to increased intracranial pressure and swelling.
Is
And
the shape of the curve similar? Well, yeah, or the position of the curve, is it no more space to the right in children, in neonates?
well, that's a different yeah. So when in majority of pediatric patients, when we're talking about ICP targeted therapy, we normally not stick an ICP wire in under 3 months.
Yes, and it was closed.
Yes, and that's an interesting question, and we are not sure, although they have open fontanelles and sutures. Depending on how fast the intracranial pressure rises, whether there would be enough room to accommodate for that or not. If you remember, Naz, there was that 5-week-old child who was clearly abused and died. I have never seen a fontanelle as taut. It was like rock. She had bled massively. She had ventricular blood. The neurosurgeons took her to theatre overnight, stuck an EVD. The EVD was put on flow, but the ICP just were because the ventricles were like slit. She had intracranial pressure was so high. She had fixed dilated pupils by the time she arrived. Yes, yeah. I've been to court for that one. I'll never forget that. I'll never forget that fontanelle. So even though they were only 5 weeks old and they had an open fontanelle, they couldn't sustain. But clearly, I don't think anyone ever does a decompressive craniectomy, for example, for a neonate that size, or an infant under 6 to 8 months old. The youngest I have seen with an ICP wire was 2 years old, or 2 months old. Sorry, not 2 years old. So that's true. If it is slow, then of course you may not notice that the child has raised intracranial pressure. And only this morning I was telling you about those babies or kids, infants we would have in India who present with post-TBI, TBM, post-tuberculous meningitis, like huge heads with some setting. I mean, their head would be so full of fluid that you could put a torch and it'll illuminate, right? I don't know if you remember, Sunil. And because the pressure rise would be so slow that the head would have enlarged and nobody would have noticed, and they'd come with the head the size of their abdomen. It's just like crazy. But if it rises very rapidly, as in that trial, clearly the curve would, it only just depends upon how rapidly the pressure rises. So what we're doing when we're talking about ICP guided management is essentially trying to prevent ultimate herniation and of course ischemic damage to the brain, which is the last common pathway of all these. And as I spoke very briefly about, we paid less attention to the venous compartment. There is an increasing recognition that needs to stay open. So of course, everything that can add to the back pressure, from abdominal pressure, intrathoracic pressure, we worry about using very high PEEPs in these children. We worry about them if they have significant lung injury in relation to their traumatic brain injury, because we know that we'll need to use high pressure ventilation and that may not be good for the venous compartment. And we always look for whether or not they have a fracture anywhere in the proximity of the venous sinuses and cause clots in those. We've had a few in pediatrics in our patients recently. So there's an increasing understanding of that, and people are talking about stenting the sinuses open, etc., to try and improve the venous drainage. Of course, the most frequently used intracranial monitoring in pediatrics, or in UK, I should say, across adults, is intraparenchymal. The gold standard so far was considered the EVDs, but there are problems with the EVDs because they are technically more challenging to insert. They can cause more hemorrhage and infection, and they need to stay closed unless they have a probe outside the actual draining channel, which can record continuous ICPs. And equally, if the system is open, how do you say this is intracranial pressure? Because it might have equalized to a certain degree. But interestingly, there is more recent evidence, both in pediatrics and adults, to suggest that those who had an early EVD insertion had worse outcomes. And people are starting to talk about the glymphatic system which might be drained or affected by EVD. And there's been a transatlantic divide between using EVDs and intraparenchymal. And people thought that if they had an early EVD insertion, they also had CSF diversion. So if the ICP was high, they could just open the channel and remove it. But clearly that's showing worse outcomes. Intraparenchymal drains are intraparenchymal probes are much easier to insert. And I know not here in UK, but in some countries, the intensivists do it by themselves.
You've done, well, in ours, they do it at the bedside.
Yeah, we here also they
Yeah.
do it bedside. Unless the child needs to go to theatre for something,
Right.
they'll come and do it here. So, and then there are all kinds of other parameters which we are not going to talk about. And this is just an old paper, but what was most interesting out of this is that, like, if you look at it, a lot of the ICP spikes were not picked up by the EVD. So for us, we would put an intraparenchymal wire, and EVD is used if the ICPs are very high and if there is room. So it's not used in the first instance, and then only used at the in the lower incidence. So yes, I mean, of course, the number is something which is easier for our brains to understand and for everybody to follow bedside. But equally, it's not just about the number, as we've seen accumulating evidence. It's also important to look at the waveform and try to understand whether it's not moving. So when we look at the actual waveform, forms three, it's made of three different peaks. So P1, which is the percussion arterial stroke, the P2 is the tidal rebound wave, and then of course P3 is the dicrotic venous, which is the and normally you would like to see all three of them in that order. So if the P2 is suddenly bigger, then of course, because it's reflecting mainly the venous compartment and the brain compliance, you're more worried about it being a low compensatory reserve state. So you'd like to treat it more aggressively. And I think we are all guilty of the fact that we miss out on looking at the waveform. We're just so happy looking at just the actual numbers. So this is what we mean, and we've seen this curve, the volume pressure curve, earlier as well. And stage one is, of course, the normal state, and stage two is where we start worrying about, because we know any little changes here would lead to a low compliance, high elastance state where the ICP would rise exponentially, and if we could not manage it, the outcome is going to be poor. So this is what I was talking about by using the clever calculations. Of course, the pulse waveform we saw, and that's a good indicator if we would just look at the bedside monitor. But clearly there are some clever calculations happening with the clever softwares. The one that Cambridge has developed, ICM Plus, can incorporate all the waveforms and then work out on the actual pulse wave amplitude against the actual ICP value and give us an indicator of the compensatory reserve. So if the RAP, as it is called, is close to 0, that suggests good compensatory reserve. If it is close to 1, then of course it shows poor compensatory reserve. And this is what the graph I was talking about earlier in terms of the actual ICP insults with CPP below the lower limit of reactivity in comparison to above the lower limit of reactivity. So as we can see, when the autoregulation is deranged, basically even the smallest spikes in ICP would be far more damaging than otherwise. And this is a huge issue for pediatric populations, because we are still trying to manage their ICPs below 20, which is what we'd use in adults. And we know that there's an entire developmental trajectory, and possibly the younger age groups should have lower ICP targets than what we would use. This is just to say what we tend to do when we're talking about ICP. So as we saw, it's a function of the 4 different compartments, if we can call it, if we split the arterial and the venous compartment separately. The arterial blood inflow we manage by managing the vascular tone by using inotropes plus minus the fluids. The venous blood outflow we manage by keeping the head up. So that's gravity helping with the venous drainage. Sometimes using thrombolysis if we see a sinus venous thrombosis. And of course, stenting. The CSF circulation we manage with external ventricular drain. And of course, lumbar drainage is talked about. I have never seen it being used clinically in any patient. It's probably one of those theoretical options available. And brain volume, of course, the hyperosmolar treatment that we would use. These are the different treatment strategies we could use for each of the different components that we know contribute to intracranial pressure. What did I do that change there? Right, so well, of course, I've talked about it already. So the treatment threshold as defined by the guidance is less than 20. And that's mainly to do with the fact that those patients who did not live after a traumatic brain injury had an intracranial pressure above 20. Well, we don't really know if that's the right treatment threshold. It gets a little bit more tricky when it comes to CPP thresholds for pediatrics. So the guidance recommends that we should maintain a minimum CPP of 40 or above for the lower age range, and for older children anywhere between 40 to 50, but they do acknowledge that we might need to maintain it above 50 in the older age groups, and it might be appropriate to use some age specific thresholds, but there is no evidence to support anything better than that. So this is how the algorithm looks like. We've got a CPP pathway, you've got an ICP pathway, and then there is also an additional brain tissue oxygenation pathway. And the recommendation now is that if we, for any reason, want to use hyperventilation as a strategy to manage intracranial pressure in tier 2, then we should only do it with brain tissue oxygenation. And how that helps is because the biggest worry we have with hyperventilation, and that's why we're so fixated on the CO2 levels between 4.5 and 5, is that we do not want to cause cerebral vasoconstriction and ischemia with lower CO2s. So if we have brain tissue oxygenation, we can at least assess at what level of CO2 we are causing brain tissue ischemia and monitor it according to that. So the recommendation is to use hyperventilation to the point that we are not causing brain tissue hypoxia. Clearly, the limit that they have set of more than 10 is still being debated, and whether or not that's the right thing is something we need to look at. The other main new thing that came into it was the hypertonic saline infusion, which did not exist in the pediatric recommendations previously. So we've imbibed that in our population. And then, of course, the herniation pathway, which is fairly standard. If there are any signs and symptoms, we do an emergency management bolus with hypertonic saline, hyperventilate, and then take the patient for emergency CT scan. And this is for those who have who are refractory to the first year treatments, repeat CT, of course, if required, surgical intervention, and or barbiturate infusion, moderate hypothermia. Now, we do not have 32 as the lower limit for us. We have kept it as 34 and above, and mainly because at 33 and below, not within pediatrics, but the adult setting, they have seen brain tissue hypoxia and an increased threshold for seizures. So we don't tend to use that. And then, of course, they're making additional recommendations for advanced neuromonitoring and PRX. The pressure reactivity index has finally made it into the pediatric guidelines for the first time, which didn't exist in the past. And this is just to show why we are so fixated on brain tissue oxygenation when it comes to hyperventilation, because there's a clear evidence to suggest significant ischemia with lower CO2. So we might be reducing the ICP, but then we would cause significant damage. And so this is what we use for our patients. These are our guidelines. So we call these a baseline neuroprotection, followed by tier 1, where we are adding hyperosmotic therapy, optimizing ventilation and sedation, blood pressure, and if then required, follow on to surgery, hypertonic saline infusion, and hypothermia. And then if still not in the last year, we have recommendations for using thiopental plus minus the decompressive cranial.